And so lastly, I just want to introduce Dr. Cow. Dr. Cow is one of my colleagues in the sleep clinic where I also work. She's a pulmonologist, so she deals a lot with the breathing disorders, which are very common in MSA.
Hi, so I'm really glad to be here, and thank you, Dr. Mix, for inviting me. My background, I'm a pulmonologist and a sleep specialist, and I actually am part of the multidisciplinary team for the neuromuscular disease clinic, but I also see many patients with MSA as well. Okay, so hopefully I'd like to just in the 15 minutes give you kind of a framework or a checklist of the sleep disorders that come about from MSA. Some are directly related to MSA and others are not related but can affect MSA seriously. Okay, so when I think about sleep disorders for MSA, the common sleep disorders are listed here. So in central is MSA, but you have people with insomnia or circadian rhythm dysfunction. So insomnia is actually a very, very common problem for MSA. It has the highest prevalence. And then there's excessive sleepiness. So many people complain of daytime sleepiness. The other common one is the REM sleep behavior disorder. This is a condition where during sleep, especially during deep sleep, when people are dreaming. So during dreaming, people actually are paralyzed, but in REM sleep behavior disorder, people act out their dreams. So the dreams can be quite violent to the point where they can harm themselves or their bed partners. The other very common category is sleep disorder breathing. So being a pulmonologist, I will discuss this a little more as well. And this is actually the category where many MSA patients can die from. And then restless leg syndrome is also very common and tends to cause a lot of insomnia as well. So insomnia, I wanted to focus on this because it has the highest prevalence in MSA patients, about 75%. So patients complain of sleep fragmentation. They have a hard time just staying asleep through the night. Interestingly, sleep onset is not a problem. So they can actually go to bed and fall asleep. But the problem is they wake up in the middle of the night and then they can't go back to sleep and they wake up frequently. So sleep maintenance insomnia is the biggest problem. Many people have early morning awakenings, and this needs to be differentiated from depression as well, as depression can also cause early morning awakenings around 4 or 5 a.m. So insomnia here is, again, I put here in the middle, and you can see that there are many categories. So there's 4 main categories, but many disorders here can cause insomnia. So neurochemical abnormalities, so just the degeneration of the sleep-wake pathways in the brain from the MSA can cause circadian rhythm disturbances and so forth. Medications themselves can also cause sleep disturbances. So motor disorders, right, akinesia, changing positions, difficulty with positions, with discomfort, pain. Dystonia and pain are very big problems with insomnia. Psychiatric disorders, again, so anxiety and depression are common and unfortunately can cause a lot of insomnia. And the other category that's really kind of the elephant in the room here is the sleep disorder. So there's the sleep apnea syndromes, stress of urinary frequency many times during the night, and so that can cause sleep fragmentation and disruption. So for sleep and breathing, I break into 3 categories. So there's sleep apnea syndromes, and obstructive sleep apnea is one category, and then the other one is the central sleep apnea. Obstructive sleep apnea is basically upper airway obstruction, so vocal cords up. You can have many MSA patients already have this pre-MSA diagnosis. The MSA can worsen the obstruction. Central sleep apnea will occur if the neurodegeneration affects the brainstem, and so it'll cause degeneration in the central respiratory control center, which can cause central forms of sleep apnea. Vocal cord dysfunction or paralysis is a huge problem. This is a category where patients can die suddenly, can die during the night, and so this is something that I'll talk about a little more. And then airway clearance is also another big category. A lot of patients have many problems with saliva, clearing secretions. Aspiration pneumonia is one of the biggest causes of death, and so we can focus on a little bit as well. So me not being a neurologist, this is how I look at different parts of the body. Because this is still brain. This is where the central control center is for breathing. It's kind of like the pacemaker in your heart that keeps beating. And here's the neck area. This is where the nerves are innervating the muscles for breathing. And then you have your lungs, of course. And then you have your chest wall, right? Your rib cage, your muscles that are surrounding the chest wall to help your lungs expand and inhale and exhale. And then, so these are the 4 areas where breathing can be affected. Depending on where the MSA is affecting the patients. Usually it's multiple areas. People have a lot of problems with upper airway, vocal cords, obstructive sleep apnea. Airway clearance becomes an issue here because a lot of people have dystonia, stiffness, and that will inhibit the ability for your lungs to expand fully. And so over time, you have problems with airway clearance, cough, and so forth, which can cause lung collapse, aspiration, and so forth. So the upper airway is it's diagram here, and I just wanted to show you that this is where the obstruction usually is for sleep apnea. Of course, obstructive sleep apnea is something that can happen pre-MSA diagnosis, but the vocal cords are around here, and this is where with MSA patients, the muscles that innervate that basically control the vocal cords in terms of opening and closing can be affected, and so that can cause vocal cord paralysis and either progressive shortness of breath or acute shortness of breath leading to suffocation and sudden death. So nighttime symptoms, so snoring, of course, it's very common. The high-pitched noises from breathing, this is a sign that your vocal cords may be affected initially during sleep before it becomes a daytime problem. And then, of course, frequent awakenings from sleep, disrupted sleep, breathing pauses, which the patient would not know, but the caregivers may recognize, gasping, choking from sleep, and then shortness of breath, of course. So daytime symptoms are a little bit more evasive in terms of, it's not always clear that it's due to shortness of breath or sleep problems, but morning headaches can be due to low oxygen or high carbon dioxide during the night. Excessive daytime sleepiness, daytime fatigue. These are really signs that you're not breathing well during sleep. You don't know that you're not breathing well, but it translates to daytime sleepiness and daytime fatigue. And then as a consequence, you compensate by taking frequent or longer naps. So if you're already taking naps to begin with pre-MSA diagnosis, one of the things I want to know is, are you taking more frequent naps or are you taking longer naps? So voice hoarseness, this is what I always look for this because it's a early sign of vocal cord problems. Shortness of breath, weak cough, I always look at airway clearance. I always ask the patients, what is, can you cough? How do you clear your saliva? How is swallowing? All these things are really big issues with aspiration. So there are some tests that we do to test for breathing disorders during sleep and during the day. Of course, many of you have probably have gone through the overnight sleep study. That's a very comprehensive gold standard sleep study where we test for breathing problems during sleep, of course. But the nice thing about the sleep study is that it will test for more problems in other conditions unrelated to breathing, such as the REM behavior disorder, restless leg, and so forth. So there's other disorders that I can test for beyond just breathing. So pulmonary function testing is something that we do, me as a pulmonologist, and this is really a test for daytime breathing problems. So for patients who come to my clinic, I routinely do this before I see the patient so I know what I'm dealing with. However, I will say that, many patients in the early stages of breathing impairment will have normal pulmonary function testing. So then that's when I really try to get the sleep study because I want to know what's happening during the night. Many of you may say, well, what about the home sleep study? Because I know patients hate coming in for the sleep study. In this scenario, home study is probably not adequate. The home study is really designed to look for straightforward obstructive sleep apnea, and it does not detect anything else that's more severe. So, all right, so let's talk about aspiration preventions. So what I always tell patients is try to sleep in a semi-upright, about maybe 25 to 30 degrees inclined with the head of the bed elevated. That might be a little bit tough to do. Wedge pillow can do it. Some people have beds where they can put bricks or books underneath their bed, the legs of their bed, or they have the kind of mattress so they can actually raise it up. And then reduce aspiration risk. So changing food consistency. And this is where the speech therapist can really help as well. Speech therapy is here. Hydration is key to keep your secretions not so thick and difficult to bring up. There's oral suction devices that I will prescribe to help clear out secretions. And then, some patients, many patients will need feeding tube placement. And then at the last resort, tracheostomy. Now, tracheostomy is obviously indicated for breathing problems, but people who cannot protect their airway, whose saliva and secretions go down the wrong tube, the trachea to the lungs, the tracheostomy can prevent that. So that's when we would recommend that. So excessive oral secretion saliva. It's not that you make more saliva because of MSA, but your muscles of the upper airway are weak, and so you cannot clear the saliva, so it accumulates. So what we do is we have medications to try to break up the thick secretions. We have medication to dry out the secretions. There's Botox injections. And then there's mechanical exsufflator. These are cough assist devices that we use routinely to really help patients bring up the secretions because they can't do it themselves. So this is an example of, so the cough assist is something that I really recommend highly for my patients. The benefits are immense. So not only does it bring up secretions for those who can't clear it themselves, but it does the main benefit is that it increases lung expansion. So it helps to increase lung volume, and over time, there's less lung collapse, there's improved oxygenation, or basically you're getting better gas exchange or air. And so this is very important, and it's used usually twice a day. And this is kind of a picture here of a cough assist, and this is someone helping the patient with using the cough assist, and something that you do about 15 minutes twice a day. So let's talk about the respiratory assist devices for breathing problems. So these are really positive airway pressure devices, or PAP. I don't call it CPAP. They alleviate symptoms. They definitely help with sleep symptoms. You get better sleep. You have improved daytime symptoms, energy level, and so forth. So they do improve quality of life. I don't think that they will delay disease progression directly. It might delay disease progression by improving other parameters of MSA. But when to start? So the earlier the better. And I know this is the thing with patients, is that when in the early stages, patients feel okay still and they don't want to start anything. But it really is easiest to start early because you can really learn how to use the device and get used to it. By the time you really need it, it's a little bit late in the game. So the PAP devices are ranging from CPAP to BiPAP or bilevel PAP, and then the ASV devices. And then there's really more sophisticated devices that are considered home ventilators, which I don't usually think MSA patients need, but some patients do. But I didn't put in this category because it's not something that's commonly prescribed. So vocal cord dysfunction or paralysis. So in this case, CPAP is recommended as a first step. CPAP is basically continuous positive airway pressure. So it doesn't matter if you're breathing in or breathing out. It is going to just blow that pressurized air in continuously. So in a sense, it's a pneumatic splint. It keeps your vocal cords open, and especially during sleep. And so this helps, but it depends on the degree of vocal cord paralysis. Obviously, if your vocal cord is severely narrow, then it's not going to work and you're going to need a tracheostomy. There's a condition called the floppy epiglottis, and this is not something that we see usually, but this is a case where the epiglottis, that little thing that hangs in the back of your throat when you're looking deep inside. So this can, if it's floppy, the problem is that CPAP, being that it's just continuously blowing air in, it can further obstruct and cause life-threatening choking. So patients can actually die acutely from CPAP if this is happening. So when I suspect a floppy epiglottis, so this is where the overnight sleep study is helpful, because it can help me determine obstruction, and then I almost always, when there's any evidence of hoarseness or shortness of breath or vocal cord problems, I always call in my ENT colleagues for the evaluation, because they can do that, the scope, and look at the vocal cords in detail. So stridor is a big problem. It's one of the biggest breathing problems for MSA. It is a harsh, high-pitched inspiratory sound due to the larynx being narrowed. And it always occurs during sleep first. So this is where we really try to elicit a detailed sleep evaluation, because by the time we see it during the day, it's a little bit later in the stage. It is a red flag for diagnosis of MSA. So if I have a referral for stridor, if I'm the first doctor seeing the patient, I would call in my movement disorder specialist. It can be life-threatening because it can lead to acute respiratory failure and death. The treatment is CPAP, again, depending on the degree of the paralysis. And then for tracheostomy, I recommend it when the symptoms are present during night and day. There's swallowing problems, if there is minimal opening of the vocal cords left. So just my next to last slide, these are some of the devices that we use for breathing. These are, I don't have any preference or anything with these companies. Is just to show you that these are the latest devices. They're actually quite small, contrary to what many people may know. The new devices are about 2 pounds. They're very quiet. Given the fact that you have to wear a mask to sleep, that's still the unchanged. But the technical advancement of these devices and the masks have made it so much easier for patients to use and be comfortable with it and get some relief in quality of life. And the lower devices are probably the most advanced respiratory devices out there, respiratory assist devices out there right now. And these are the home ventilators, where patients who need to use something for breathing during the day, then we will have to use these, because these are portable devices that can operate with battery. So my last slide in summary. So I think that the sleep assessment is essential. If there's any evidence or any signs of breathing or sleep problems, you really should see a sleep specialist and should get a sleep study to see what we're dealing with. And then the respiratory assessment is also essential for daytime breathing, vocal cord evaluation, and airway clearance. And I think sometimes you have to see, depends on where you are, but the sleep specialist might be different than the pulmonologist. So, and sometimes you can combine two into one physician. But anyway, so hopefully you have a sense of what you're looking for in terms of breathing and sleep. I think that's it. Thank you.